And kind of along those same lines, after prognosis, how do you approach and structure treatment planning to balance maternal, status and fetal safety, including decisions around surgery, systemic therapy, and the timing of all of that?
Yeah. So a lot of this hinges on, again, a multidisciplinary conversation with the surgeon and with the maternal-fetal medicine specialist and the medical oncologist. A lot of it hinges on a few factors. One, which trimester are we in? And two, the wishes of the patient should absolutely be taken into consideration. And three, again, looking at the estrogen receptor, progesterone receptor, and HER2 expression. We know and have a fair amount of safety data with certain regimens for chemotherapy, and have been safely been able to use those treatments while awaiting for hopefully as close to a full term viable pregnancy as possible. There are certain treatments that are contraindicated in pregnancy. Um, Things just like hormone blocking pills are not safe during pregnancy. If radiation is needed, that needs to wait until after pregnancy. There is limited safety data with the immunotherapy like pembrolizumab in this space, but when you're treating a patient with breast cancer, um, sometimes surgery goes first. But if you're looking and doing a lumpectomy, which is a partial breast removal, you have to factor that timing into where radiation can be safely given. And so if there's going to be a prolonged period of time in between those two, maybe doing some other treatments and waiting before doing surgery would make sense. But so much of this is individualized, and also while we're doing these treatments, making sure that the MFM team is closely monitoring
Mhm.
babies to make sure that baby is continuing to do well as well as mom.
And especially with younger patients and you seeing more younger patients, what are some of the main points you cover when counseling patients about fertility preservation, future pregnancy, and even breastfeeding after treatment for breast cancer?
So, in non pregnant patients who are young, who desire um, options and discussion about maintaining future fertility options, there are things that can be done prior to initiation of chemotherapy because chemotherapy can increase rates of infertility. Um, Meeting with a reproductive endocrinologist in a timely manner is very important because there can be egg retrieval and other interventions that can be done prior to administration of chemotherapy, and those conversations are important. In addition, during chemotherapy, there can be medications given called GnRH agonists like gaserelin that can work to shut down, do ovarian suppression and it has been shown to decrease rates of infertility while you're on chemotherapy.
And just kind of looking into the future, are there any emerging data or practice changes that you think will eventually or significantly impact how we diagnose or manage breast cancer in the next few years?
Next few months, these I very much enjoy being at an academic institution where I get to educate fellows and medical students and residents because there are constantly studies that are changing the practice of medicine. There are constantly new drugs across all different subtypes. And um, both the challenging and wonderful thing about breast cancer is so many of these patients, regardless of what stage, are often being followed 4 years, which means these trials, in order for them to mature to show data, need to be followed 4 years. So there are a variety of studies we're always awaiting for the final results on, or for interim results that are being released at conferences so that we can give our patients the best care that we have, and that will continue for many years to come.
And if you could leave listeners with one practical consideration to keep in mind when encountering complex or atypical breast cancer cases, what would it be?
Patients know their bodies better than anyone. If they are feeling something that's abnormal, it is never wrong to go and address it. It is unfortunate sometimes we catch cases of breast cancer where people have, for one reason or another, could it be financial restraints? Could it be time restraints? Could it be, worries about what this could be? And we can catch breast cancers in more advanced stages. The more advanced stages, the less likely I am to be able to cure this. So being mindful of your body, and when you notice changes, to let someone know to do those investigations, do those mammograms, do those ultrasounds.
Wonderful. Well, it's been a pleasure talking to you, Dr. Rader. Thank you so much for joining us on MD Newsline.
I appreciate your time. Thank you so much.